Namaste, Shubha Madhyana. I welcome you all to Tadvidya Sambhasha Parishat Shalya Tantra sessions. Today we are with the 11th session of this series. Before we start today's class, we will start with a small prayer. Om Namami Dhanvantarim Adidevam Sura Surair Vandita Pada Padmam Loke Jararubhaya Mrityunasham Dataramisham Vividaushadhina. Okay. Welcome everybody again. So today we are with the 11th session, as I told earlier. So in the last class, we were dealing with diseases of the spine, and we mainly dealt with Pott's spine under that, which is important under the category of disease of spine. So we briefly saw the classification of diseases of spine, and then we started off with the Pott's disease, that's the Pott's spine. So we saw how the pathology occurs, what were the types of pathology, what are the types, different varieties of pathologies, and then we saw the clinical, up to the clinical presentations. So in today's class, it's going to be a little, a very small class compared to the others, because we will end with the Pott's spine, and in the next session we will start off with the new or the fresh topic. So today we will be dealing with the further aspects of how the examination goes. So what are those things which we have to observe with radiological examinations, each of it, that is the X-ray, MRI, CT, each and everything, and how important it is for the differential diagnosis of this case, and then the treatment aspect. So let's continue. So before we start, I hope the last session, what we saw the actual relevant anatomy of the vertebra. So that is very, very important in understanding the pathology or the different types of pathology of the vertebra. So we saw the anterior segment, we saw how the body, the pedicle, lamina, how the posterior complex forms. We saw the different ligaments that holds the vertebra in place. So that was with respect to relevant anatomy. Again, as a continuation, we will further see how do we take forward the examination part of it. Okay, so the first thing what we have to look here is, so in the last class, just to brush up, what we saw was the presenting complaints. So under the presenting complaints, we have seen the following things, that is the pain, stiffness, which are the basic, that is which are the prime symptoms. Then we saw the evidence of abscess in the presenting complaints, that is the cold abscess. And next we saw what was paraplegia, deformity. These are with respect to the complications in further advanced stages of Pott's spine, deformity associated with the corresponding segment, whichever is the corresponding segment, the spine is affected. And then we saw the general constitutional symptoms. So we had seen how the patient presents to us with the presenting complaints in the last class. So in today's class, we'll be moving on with what are the examinations and what are those important things which we need to give an extra look upon so that we get things in place. So the first thing what we have to look for under the examination today is okay. So why is an examination of the Pott's spine very important, or what are the principles of examination behind the examination of Pott's spine? So the first thing what we have to, why it is done is, the aim of the examination here is to pick up the findings suggestive of tuberculosis. Suggesting TB. So this is the first aim. Now after we have gathered all the important findings on whether it is suggestive or whether it is for tuberculosis or not, the next thing what we do, or the examination aim, is to localize the defect. Okay, that is which segment or which part of the TB is, or which part of the vertebral column has been inflicted is the second aim. That is to localize which of the part of the vertebral column is involved in this spine is the second aim. Now the next thing what we have to do is, suppose after all of this, the next important thing of examination is to detect if there is any complications. If there is any complications associated. So these are the main three basic principles of examination that we undertake under the port spine. Now moving on further, how exactly it is done. So first thing what we look under the examination is the gait of the patient. Okay, now the first thing is gait of the patient. Why it is important to look for the gait of the patient? Patients with TB, afflicted TB for the spine, they usually tend to take small steps because they do not want to, or they want to avoid any jerking of the vertebral column. So in an attempt to that, any jerking will aggravate the pain symptoms. That is why any patient of with TB spine, he tends to move with short steps to avoid any jerky movements of the spine. So this is first thing. So first what we have to look under gait is this. Now suppose for example, even another important thing what we have to look for during the examination is, we have to look for the fashion in which the patient is lying on the examination table. Like for example, if the patient coming to us is a suspected case for TB cervical spine, then what happens then is that, suppose when the patient wants to lie on the bed for examination, he tends to protect his cervical spine or the chin with both the hands, and he wants to lie down very, very cautiously, taking both the supports of the hand. So that is one thing. So this is with respect to the TB cervical spine. So in any case it might be, or even suppose you ask the patient to turn behind. If the neck movement is not appreciated, the patient tries to rotate or turn the entire body. So it's an attempt to avoid any jerking to the cervical spine so that it aggravates his symptoms. So this is an example with respect to the gait. It is with respect to whichever is the localized segment. It might be cervical, dorsal. So with respect to that movements or that locomotion will be guarded by the patient himself. So the first thing we have to look under examination is the gait of the patient. Now the next thing what we have to look is the deformity. Okay, now with respect to deformity, what is that we have to look for? Now, usually significant deformity is absent in cases of the lumbosacral spine. If the TB is localized at that area, significant deformity to be elicited in an examination is usually less. But suppose it is in case of a cervical spine, it is very evident with a stiff neck. In case of cervical spine. Okay. Also in case of the dorsal spine, we saw in the first session what is called as the nimbus or the kyphus. That is a small portion of extra prominence of the spine dorsally. So that is called as kyphus or nimbus. So this is in case of the dorsal spine. As I told, with case of lumbosacral, the deformity is less evident. Okay, it is less evident. So this is the next thing what we have to look. So we first saw the gait. Next we are seeing with respect to the deformity, when in case of cervical spine affliction, there is stiffness of the neck. Suppose if it is in case of dorsal spine, then there is kyphus or the nimbus, that is the exaggerated prominence of the vertebra posteriorly. Next is in case of lumbosacral, usually any deformity to elicit in an examination, in a clinical examination, it is a little rare. Okay, so the next thing what we have to look under this examination heading is the paravertebral swelling. Okay, so the next thing is, after deformity, is the paravertebral swelling. So what are we trying to look here is, as the name itself suggests, paravertebral swelling. So we are trying to elicit if there is any superficial swelling that is palpable to our hands, just besides the vertebral column. So in cases of superficial cold abscess. So what is the swelling that could be happening in case of TB spine? As we have seen in the last session, it is nothing but the cold abscess because of accumulation of the pus and the debris. So suppose that cold abscess is situated superficially, then definitely during the examination, when you are examining the patient with palpation, we can appreciate the paravertebral superficial swelling in case of superficial cold abscess. Okay, so this is the third important point what we have to keep in mind while examining the patient suspected for TB spine. Now the next thing what we have to look for is tenderness. Okay, the next thing is tenderness. So here what are we looking, where exactly we are trying to elicit the tenderness is at the level of usually while it's an maneuver where you're trying to, as if to twist the spine. So in such an action, suppose if this is the vertebral column, so we hold it like this and we try to rotate the spine. So in such a process, the pressure is on the spinous process. So back by palpation and also in an attempt to rotate the spine, so patient will complain of increased pain. So that is for the examination of the tenderness. That is in an attempt to, as if we are trying to rotate the spine. And there is excess tenderness at the spinous process. Okay, so this is the next important thing what we have to look for under the examination heading. Now the next thing what we look for is neurological examination. Why neurological examination? Because there is another entire content called as POTS paraplegia, where under that heading, all the neurological entities which fall under the involvement of TB spine are categorized under POTS paraplegia, wherein because there are again many pathologies involved. It could be a bone that is a vertebra that is injured there, or it is being destroyed there, that could move inside and affect towards the spine and cause neurological deficits. So wherever is the nerve lesion involved, or wherever the nerves are being injured because of this pathology, so the entire thing comes under POTS paraplegia. So under that, because of that, to rule out that, we also have to take up a neurological examination. So under neurological examination, what we are doing, so we have to look for whichever is the segment of spine affected. So we have to go for complete examination of that particular limb, either the upper limb and the lower limb. Along with that, we also look in for all the sensory and motor reflexes or the examination. Along with that, another very, very important thing under neurological examination is that you have to examine for the urinary bladder and the defecatory physiology. So these things come under the examination of neurological examination. That is, we are examining with respect to the upper limb or the lower limb, whichever is the localized segment of the spine, and then we have to compulsorily go for the motor and sensory reflexes. Along with that, it should also involve an assessment of the urinary and the bowel function. So we have to go for the urinary functions and the bowel functions. Both of them also have to be assessed under the case of neurological examination. Now the next thing, the examination always ends with, we know we have been seeing constitution symptoms under the presenting complaints. So it also is mandatory to go for a general examination. So this was specific with respect to POTS spine. So with the examination always ends with the general examination of the patient. So we saw what the presenting complaints were, like pain, stiffness, cold abscess, etc. So now we are starting, we saw about the examination. So how the examination starts, the first thing we have to assess is with respect to the gait of the patient. So we now know that with respect to whenever, because the entire spine is affected, so the patient always try to take short steps to avoid any jerky movements of the spine. So we look for the gait, we look for the deformity. Deformity here is with respect to the, you are trying to localize the lesion. So under the general aims of principles of examination, we saw that first thing is to pick up any signs suggestive of TB spine. The next aim what we saw is to, suppose you get a finding which is suggestive of TB spine. The next important thing we have to do is which particular part of the spine is this lesion or the pathology located. So that is very important to be ruled out. So all this deformity and gait, all of these will help us to locate the exact lesion of the pathology, or exact site of the pathology. The next thing what we are looking is for paravertebral swelling. So in cases of superficial abscess, that is a cold abscess in case of TB spine, so that can be palpated, and it is why, because this cold abscess is usually very, very fluctuant. So that is why it is easy to palpate if it is located superficially. The next thing we have to look for is the tenderness at the spinous process. Next, it should end with neurological examination and the general examination. One thing we are not supposed to forget under neurological examination is to check for the reflexes of the bowel and the urinary output. Okay. So the next thing now, we saw what the examination could be, but TB spine is one such thing. It will not give you an exact conclusive diagnosis with only examination, and radiological examinations plays a vital role in confirmation of the diagnosis. So with all this clinical examination, so what are the radiological examinations that we have to do? And suppose we are advising an X-ray. So what are those things we have to look in an X-ray? What are those things which can be picked up by CT and MRI? All that we'll see now. So now we are moving with investigations. Okay. Now, under investigation, so the first important investigation is the X-ray. So always it has to be remembered that two view is very, very important to any kinds of X-ray. So here also it is usually the AP and lateral view. Anytime, never we have to come for a conclusive diagnosis with only one view of an X-ray, whether it might be a TB spine, whether it might be fracture, whatever it might be, two views are always mandatory. So here, it's also with respect to TB spine, also it is, first is the AP and the lateral view. And it is also important that we cannot just advise for an X-ray of the entire spine with whatever examination we have done, with whatever doubtful diagnosis we have come to localize the lesion. So you have to specify which is the part of spine you want to project the patient to an X-ray. Suppose you have, in the examination, we have seen stiffness of neck, the gait of the patient, he's always supporting his neck with hands at the chin. So all of these are there. And there is tenderness also at the level of cervical spine. So it's suggested that it could be a TB lesion at the cervical spine. There could be skip lesions, there could be lesions somewhere else, but with our diagnosis, primarily we feel that it is there. So while we are suggesting an X-ray, we have to suggest X-ray AP lateral and maybe C spine or lumbosacral or the dorsum. Wherever is we have localized with examination, we have to specify the exact site when we are sending the patient and we are prescribing for a radiological examination, that is the X-ray. Now, the next thing what we have to keep things that are to be seen importantly is, now we have an X-ray film of the patient. What are those important things we are to be seeing now? So, the first important thing is the reduction of space. That is the disc space. Okay. Now, what is reduction of disc space? So, in the last class, we saw the entire anatomy of the vertebral column. So this is one vertebra. This is the another vertebra. We have a disc here. Fine. So we saw, suppose this is a case of paradiscal type of pod spine, as we saw in the last session. So first thing that is to appear on the radiological examination, that is the X-ray, is the reduction of the disc space. So this space keeps on reducing. Okay, so initially it is not, in very initial stages of the pathology, it cannot be picked up that easily. So it is better to always measure whichever is the suspected site with the disc space above and below it. So we need to, with the X-ray film, we have to measure the suspected disc space which is reduced with the disc space above it and the disc space below it. So this is the first thing what we have to look for in an X-ray. That is the reduction of the disc space. Now, the next thing is, like as we said, in initial stages, this is difficult to assess. But in certain advanced stages, you could see that the disc space could be completely absent. Why? Because we saw in the pathology in the last session that there will be destruction of the bone, and because there will be reformation or the formation of the new bone where there is presence of sclerotic bone, and at the end both the vertebra fuse, and that fusing, however it fuses, that remains as a lifetime deformity. So that is why in advanced stages, maybe by the time patient comes to you in an advanced stages, it could also be that there could be total loss in the disc space. So that is very important. Now the next thing what we have to be looking for is the destruction of the vertebral body. This is the next important sign or important thing what we have to look for in an X-ray, that is destruction of the vertebral body. So in the beginning, if suppose this is the vertebra, how do we assess the destruction, or what is the fashion of destruction is that there will be destruction in the margins in the beginning. Okay, and in the next, as we discussed in the last class, two types of destruction. I said usually it is the wedge shape, or this is the concept in a variety. Usually it goes for a wedge shape destruction. So initially the destruction of the vertebral body, it starts, at the contiguous margin, whatever it is present, it starts destructing or eroding. So that is the first sign which we can appreciate under destruction of vertebral body. Now the next thing is what we have to look for is evidence of cold abscess. Okay, now under evidence of cold abscess, what is that we have to be looking for? So first here we have to look for a paravertebral swelling. Okay. So what here what is that we are going to assess? Now suppose this is the X-ray film. Okay. Now suppose this is the X-ray film. So what do we have to do here is, usually it is of two types. So what do we assess in an X-ray? We assess the soft tissue swelling. The extent of the soft tissue swelling is what we are looking for here in case of an evidence of cold abscess. So what are we doing there? So here with respect to the corresponding affected vertebra, we are assessing the superficial swelling. So it is of two types. So the first thing is called as a fusiform variety, and the second thing is called as the globular variety. So you have fusiform and the globular type. So suppose, what does fusiform means? It is also called as bird's nest variety, because here in this case, suppose this is the spine, so we have a soft tissue swelling that we are looking for. The shadow which we tissue, it's the shadow in case of X-ray, soft tissue swelling shadow. So in fusiform variety, the length is greater than the breadth. So it looks like a bird's nest. That is why it is also called as the bird's nest type or the fashion. So in fusiform variety, the length is greater than the breadth. And in globular variety, again, it's the opposite. That is, the diameter is more than the length. So what we have to, what is important between these two varieties is that in case of globular variety, it indicates that the pus inside here is very, very tense. This is a tense variety of the swelling. So here it is, it is more accumulation of the pus, and this globular variety of cold abscess that could actually give rise to a complication of the Pott's paraplegia. So the neurological complications, what we saw, what could happen, because as a complication of pot spine arises because of the globular variety of the cold abscess. Okay, so this is one thing what we have to look for under X-ray spine, that is the paravertebral swelling. Now the next thing what we have to look for is with respect to the widened mediastinum. Okay, so here what is that we are looking for? So in widened mediastinum, so it is assessed well in case of a AP view of an X-ray. So here an abscess from the dorsal spine. Now suppose we have suspected in the examination that we are palpating a superficial abscess at the level of dorsal spine. So usually we have to look for a widened mediastinum, that is with respect to the abscess at the dorsal spine. So this is one thing we have to look for. Now the next thing what we have to see, the third thing what we have to see is, for example, is for a retropharyngeal abscess. Okay, now what retropharyngeal abscess indicates is that, so it indicates especially in cases of cervical spine with abscess of C-spine. Now, how is that we are going to assess the retropharyngeal abscess? So, normally, usually, the soft tissue shadow in front of the C3 vertebral body is 4 mm thick. So, suppose this is C3 and we have a soft tissue shadow which is normal. So, this is 4 mm thick is normal. Now, suppose this is more, then it indicates a retropharyngeal abscess which is relevant with respect to the examination. So this indicates a cold abscess because of the affliction of tuberculosis at the level of the cervical spine. So this is to assess the cold abscess at the level of cervical spine. Now the next thing what we, another thing we have to see is the psoas abscess. So for the psoas abscess, I mean for the lumbosacral, we have to look for the psoas shadow. So assessing the psoas shadow, we get to understand the normal compared to the normal to the an excess in the psoas shadow. It indicates a presence of a abscess there. So this is with respect to X-ray. That is with respect to paravertebral swelling. What are the types of variety? What could we could see is, one is the fusiform variety and a globular variety. Always the globular variety has to be is more dangerous. That is, it indicates that the pus collection is more. It's the tensor variety of the abscess. The next thing what we have to be looking for is, suppose in case of the dorsal spine, we have the indication of, in the film we get to see a widened mediastinum. In case of retropharyngeal abscess, we have to look it at the level of C3 spine. That is the soft tissue shadow at the level of C3. So this is assessed better in the lateral view. And next we have the psoas shadow. So while assessing the psoas shadow of the X-ray, we get to see if there is a presence of psoas abscess. So this was with respect to X-ray. Now the next thing, so along with this, so this is the basics. So along with that, we could also assess some of the unusual signs. Like as we said, if the TB is afflicting the posterior ligament complex of the vertebral body, then there could be you could be seeing the lesions with respect to the lamina or the pedicle. All of it could be involved. So certain unusual signs or extra things we have to assess in X-ray should also be assessed for. Now the next thing what we are seeing here is the CT. So how CT helps us over X-ray is that, now usually X-ray will not pick up minute or smaller abscesses, but a CT picks up even small abscesses could be picked up by CT. Another important thing is that with CT you could even make a precise you could mark the precise destruction. What is the precise extent of destruction could be well known by CT than compared to that of a X-ray. So this is how where CT plays a role than the X-ray. So another thing what we have to look is for to assess the destruction of the posterior column, CT is better. So to assess the posterior column complex, CT plays a vital role. So this is where CT is advised. Now the next thing what we are going to do is the MRI. Now what MRI actually does, so usually it is an investigation of choice, not it is done, suppose you are suggesting it is all the findings are suggestive of a neurological involvement, then usually MRI is done because it tells you the extent up to which there is a neurological deficit. So in such cases an MRI is used. The next thing is biopsy. Suppose in all such cases you're doubtful, the diagnosis is doubtful, in such cases we can go for a biopsy wherein aspiration is done and the fluid is sent for the examination. So in such cases you could confirm the diagnosis that it is an involvement of the TB spine. So the next investigation was biopsy, and then they are the normal, other investigations are normal. You could go for ESR, you could go for Montauk's. Okay, so all of these are other general examinations that are done along with this. So ELISA, you could go for a chest X-ray. So this is to rule out the pulmonary TB, that is to the extent of pulmonary TB. So that we get to know that the primary extent of the primary pathology. So along with these, we also go for the normal ones or the common ones. So what were the under investigations we saw? The first one is X-ray. So under X-ray, we saw what are the basic signs to be seen. So first was the reduction of the disc space. Then we saw various deformities. Then we saw with respect to the soft tissue swelling. So under soft tissue swelling, so we saw the two varieties, the fusiform and the globular variety, the importance of each of them, and examples of a few, that is what are the basic signs we have to look for with respect to the C-spine, with respect to dorsal spine, that is the mediastinum shadow, and next with respect to the psoas shadow. So that we saw with respect to X-ray, and next we saw CT, how CT is better and what other things CT can pick up in comparison to an X-ray, and then where actually we go for an MRI and then the biopsy. So this was with respect to the diagnosis or the investigations. So the examination and the investigation both are combined for us to arrive at a definitive conclusive diagnosis. So with all this, examination aids you. Why an important examination is stressed upon in this case is that the examination aids you on which is the actual investigation we are looking for, so that the diagnosis may be confirmed. So the examination plays a very, very important role here. So now coming to the differential diagnosis of port spine. So what is the various differential diagnosis we have to look for is, this could be classified again under two. So first, that is the back pain, and the next is the neurological deficit. So under these headings, we could see the different possibilities of differential diagnosis. So for back pain, it could be a simple trauma that is causing back pain, or it could be any secondary CA that is afflicting. These could be the cases, it could be ankylosing spondylosis, as we saw in the last, in the fracture sessions. It could be ankylosing spondylitis that is causing back pain. So all of these need to be examined, and it has to be differentiated from the port spine. Now with respect to neurological deficits, so we have again, it could be as a cause of external trauma, or it could be because of any spinal tumor. So even that could be causing the same neurological deficit that is mimicking the symptoms of a port spine. So that has to be ruled out. Again, here the next thing is the secondaries. So these are the various differential diagnoses for port spine. So that is Simple, for example, as in the main presenting complaint as the pain. So for pain, it could be a simple trauma that could be causing pain. Secondaries of any other primary CA lesions, it could be ankylosing spondylitis. It could also be slip disc, as usually it is said, or that's the prolapsed disc or the slip disc. Even in this cases, there is back pain. With respect to neurological deficit, suppose on examination we are able to assess any neurological deficit. So it is important for us to assess between the port spine, and it could be because of any of the spinal tumor that is mimicking. It could be secondaries of another CA or trauma again. So these are the differential diagnosis for port spine. Now the next thing is with respect to the treatment aspect. Okay. Now, under treatment, what are the general principles? Like how we saw the general principles for examination, we have principles for treatment of TB spine also. So the first thing is, as usual of any case of TB, so the first thing is anti-tubercular chemotherapy. So that is the first principle, or that is the first step under the treatment of TB spine. Now the next thing is, what we have to look for is general care of the patient. General care of the patient. The next thing what we have to look is for the care of the spine. The next thing is the care of the spine. And suppose there is also the evidence of or the presence of cold abscess, then you have to treat the cold abscess as well. So these are the main four limbs of treatment for a TB spine. So here also more prompt attempt has to be done to detect, and suppose you are detecting, then to stop any complications. That is, the treatment aims at preventing any neurological involvement. Suppose when the patient comes to us, the patient is in a state where neurological deficit is not yet observed, then it is prime duty for in the treatment to see that all possible measures are taken to avoid any complication of involvement of the neurological deficit. So right now, as a part of the syllabus or as a part of the surgical care, we will be discussing of only the care of the spine and how do we treat the cold abscess. So anti-chemotherapy and the general care, it is the same as for any the pulmonary tuberculosis. So now we will be focusing on the care of the spine. Okay, so the first thing under care of spine is we get two entities, both of which are important. The first is rest in acute phase, and next comes immobilization. Okay, now when is this rest advised? So usually the rest is advised only for a short period of time, usually the bed rest, and it is mainly indicated in the active stage, and it aims at the relief of pain. So that is with respect to the rest, that is complete bed rest. So it is usually in the early stages of onset of the TB spine. The next thing what we are doing is the immobilization. Now, in case of small children, it is very difficult to advise them for a complete bed rest. So in such cases, we have something called as Minerva jacket that helps you to make the child not move. It's called as the Minerva jacket that you could be using for the rest of the child. The next thing is mobilization. The next thing is mobilization. So here what we advise is the patient is advised to slowly sit and walk when he is devoid of any acute pain, then the patient is asked to mobilize himself in an attempt to sit for some time, try to walk for some time for short steps, and during so the care, the complete care for the spine has to be looked for. So protection of spine plus mobilization. So that is what we do under this. So here usually for mobilization and also for the protection of spine, we get various type of braces that are used, and one important among them is the ash brace. So it has something like a jacket kind of material which has a center portion, and then you have something to bind it here. So it makes sure that the spine, even when the patient is moving or mobilizing himself, so even in ambulatory conditions, the patient's spine is protected, well protected. Why? Because any other jerks again will aggravate the pain and the worsening of the pathology. So that is why protection of spine along with mobilization is very important, very, very important. Or the usually used brace is the ash brace. So this is with respect to the care of the spine. Now next important under the surgical care is, suppose the patient has a cold abscess on presentation. So how is this cold abscess treated is the next entity. So here suppose this is usually for a superficially situated cold abscess. The intervention is a little more for the deeper one. So this is with respect to the superficial one. So how we are treating the cold abscess here is again by the same method, that is the aspiration and evacuation method, it's as same for that of any of the pyogenic abscesses. So in aspiration, what we are doing here is a thick needle is required, because usually the content inside is very thick caseous material. So thin needles will not serve the purpose. A thick, very thick needle is needed for the aspiration of the caseous content inside. So, and very important thing is that the needle has to be inserted in the anti-gravity fashion for the drainage. Okay, and the next thing important is the evacuation. So under evacuation method, as usual, the cold abscess is completely drained and the walls are curated. Walls curated, and one very important thing here is that usually, like other pyogenic abscesses, it is not left with a drainage. So it is usually closed without a drainage. So without a drain, that is how the cold abscess is treated, with aspiration and the evacuation method. So coming to the complications of TB spine, as we already know, so the first thing is cold abscess itself is a complication of TB spine. It doesn't seem to happen in the primary stages of the disease. So when there is presence of cold abscess, it itself is a complication. The second one is the POTS paraplegia. So these two are the complications of the POTS spine. So with this, almost we've come to the end of the topic for the POTS spine. So today we saw what were the principles of examination, what are the exact things what we have to look for under examination. We have to look for the gait, we have to look for the deformity, etc. And then we saw with respect to the investigations, what an X-ray captures, what are the necessary entities we have to look for in an X-ray, when a CT is advised, when an MRI is advised. And then we looked for differential diagnosis of POTS spine. And then the treatment aspect, the four important, one is the antitubercular therapy, and next we saw the general care of the patient. So that is common to any of the tuberculosis as the primary pulmonary tuberculosis. With respect to importance of POTS spine, that is the TB of the spine, we saw how the care has to be taken for the patient, that is with respect to rest and mobilization. And then suppose there is the complication or the presence of cold abscess, how it is it's the same procedure of aspiration and drainage. So with this, we complete the topic for diseases or deformities of the spine. So POTS spine is one major topic under the heading of disease of spine. So in the next session, we'll be moving on with a new topic. Saying so, I would like to conclude today's class. ज्ञानानन्दमयं देवं निर्मलस्फटिकाकृतिम् आधारं सर्वविद्यानां हयग्रीवम् उपास्महे। ॐ शान्ति शान्ति